everyone. Thanks for coming.
We're going to wait a moment
Okay.
to let people get settled in and see if there's anyone else in the waiting room, but we will get started momentarily with our presentation. This evening, we have a wonderful speaker. Dr. Eniolami Dosunmu is an ophthalmologist, and she's going to be sharing with us some common eye problems and symptoms of folks with Rubinstein-Taybi syndrome and emphasize the necessity for regular eye exams to monitor these problems. Celia, you think we're good?
I think we're good. We've had a little
Okay,
bit of a lull, so yeah. Oh, I spoke too
cool.
soon. I'll manage that if you go ahead and get started.
Okay, perfect. Thank you. So this evening we have an hour and a half for our presentation. We're going to go over a short welcome and introduction. Dr. Eniolami Dosunmu is going to give her, I'm so sorry I spelled your name wrong in there, but hopefully nowhere else. My apologies. She's going to be giving a presentation for about an hour, and then the last half an hour, she will be taking any of your questions. So feel free to add those to the chat, and we can monitor those as they come in, but address them when we have time. And then we have a short wrap up and evaluation. So without further ado, here is a little bit of information about our team. Celia and I are in the USED program at Cincinnati Children's. Our director is Ilka Riddle, and Celia is our family support coordinator, and I am our program management coordinator, putting some of these events together and trying to make sure we can all connect as best as possible. So here is our wonderful speaker. We're so excited to hear from her. She is a board-certified pediatric ophthalmologist at Cincinnati Children's Hospital in the Division of Pediatric Ophthalmology and an associate professor of ophthalmology at University of Cincinnati. She has 12 years of experience treating patients with Rubinstein-Taybi syndrome, and additionally, she provides care and management for children with amblyopia, strabismus, Charge syndrome, pediatric cataracts, pediatric glaucoma, medical management, epidermolysis bullosa, Treacher-Collins syndrome, and other anterior segment disease processes. So I am going to stop sharing my screen so we're able to hear from our guest. It looks perfect.
Good evening, everyone. I hope you all are well, and thank you for sharing time with us. I will try to make sure I'm mindful of everybody's time, but please feel free throughout this discussion to jump in, ask questions, or to put questions in the chat. And I know that Celia and Lauren have said that they're going to do a good job of monitoring that. Thank you so much for that kind introduction, Lauren. My name is Eniolami Dosunmu. I serve as a pediatric ophthalmologist here at Cincinnati Children's, and I've been here for 12 years now. So we'll go ahead and get started, and if it's okay, I'm just going to go over a little bit of a brief anatomy of the eye so that as we discuss various aspects, we can always reference that. And please feel free to tell me to jump back and to go back if that helps to just take a look at everything again. So looking just at a cross section, Lauren, can you see my mouse if I highlight anything
You can
wonderful?
see the mouse, yeah.
Wonderful. So looking at this is just a cross section showing the front of the eye. And in particular, I think one of the things I'll point out is just the tear duct there, which we'll be speaking about. And the next diagram here is just showing the eye from the front to the back. And the parts we'll particularly talk about are the cornea, the lens, and then we're going to talk about the retina, which lines the back of the eye, and the optic nerve. We'll also spend a little bit of time talking about strabismus. So, and that really affects the extraocular muscles. And in this cross section, you can only see a couple of those. But importantly, you're looking at the eye with a cross section sort of like that. So you can see the lateral, which is the muscle that moves the eye out, and the medial rectus, which is the muscle, if I was referring to my right eye, that moves the eye inwards. And then this is just a fundus photo of the back of the eye, putting everything into perspective. Over here, you have the optic nerve, which actually collects all the information we see and sends that to our brains, which really, the brain is really what interprets everything. The eye is just a very, very good collector of the information. And right in the middle of that is the fovea, which is where we get our best or our sharpest vision. And I know we recently had an eclipse in Northern America, and we told everybody not to stare in the sun because you could burn your eyes. And literally, if anybody did, they could burn off that specific part of the retina, and that would lead to some level of permanent visual impairment. So this just demonstrates how, like I call the eyes a good collector of the information, and how the information that goes into our eyes, how it goes into the brain, and actually part of what you see in the right and part of what in your right eye goes to part of your right brain, and the other part goes to part of your left brain. And we talk about our images decussate before it goes to the occipital lobe, which is really the part of the brain that processes the information that we see. I'm going to make frequent breaks and stops just to check in to make sure there are no questions.
There are none in the chat. Does anybody have a question?
Right,
Okay.
so we're going to go ahead and start talking about the eye findings that we would particularly see in Rubinstein-Taybi syndrome. So starting from the front, looking in, this is a photo from an article from 2000. It's a little bit dated, but in terms of how long ago it was, but it's still very relevant to us because after Rubinstein had collected a large number of patients and described what he had found along with Taybi in patients with Rubinstein-Taybi, the next big collection looking at eye findings in particular was this paper from 2000, and it was a collection of patients, Dutch patients. I particularly like this photo because when we talk about things we see in Rubinstein-Taybi, we see patients who we talk about having a down slanting pupillary fissure. And this patient here, who already had given their permission for the paper, which is why I can again share it here, you can see that. So those are one of the things you see. Sometimes I think about what you would do when you walk into a room as a physician. When I see a patient, I stop and I start putting pieces together, and that would be one of the things I would look at. The other thing I'm looking at in this particular patient is just where that eyelid crease is, which is helpful when I'm thinking about other things going forward, but also where that eyelid is actually sitting. So you can imagine thinking about our eyes like a camera. The pupil is the hole through which we see. And if my eyelid is sitting here or here or here, I can see through. Now imagine if I look through and my eyelid is sitting here, I'm effectively missing about almost half of what I'm seeing. Now, the thing is, as a child is growing up, he or she is learning how to see because every time the eyes collect the information and sends it to the brain, it sort of creates a system where the brain learns, okay, this is what I'm seeing, this is what it means, this is how I understand it. So if a child has ptosis, which is a droopy eyelid, it will be particularly difficult for you to be able to see well if you're missing half of what you're seeing. And sometimes we can see that in Rubinstein-Taybi, and then you see a child who will actually lift their head if they're particularly interested in taking a look. The other thing you will see in Rubinstein-Taybi, which can lead to some questions about a misalignment of the eyes, is an epicanthal fold, which is that extra tissue of skin that you see right there. And we talked a little bit about ptosis already. So a couple of ways we can treat that is firstly, sometimes if that eyelid doesn't always sit lower right in the middle of the visual axis and happens to fluctuate, it may still give if it's bilateral and the child can learn to keep a chin up and sees well enough. Sometimes we'll wait till the child is older because whatever we do really early in life, surgically to correct that, we know we need a secondary or a tertiary surgery. However, if it's just one side, and what happens is the brain says, oh, what? I'm trying to look at my mum here, and every time I do, I get a really clear image if this eye is in lower, but here it's really hard. And what the brain then does, it down regulates the signal it's getting from that eye, and that results in amblyopia. Sometimes you hear people call it a lazy eye, although people use that terminology for many different things around the eye. So what we as ophthalmologists do is we'll learn patch one eye so that we can get the vision in the other eye a whole lot better, especially if we're waiting to get to a surgical intervention. And the hope is right after surgery that if the eyelid stays open, both eyes are getting a very symmetric input of information that the brain learns to see well in both eyes. In terms of the type of surgeries that are done for ptosis, they're classically two things. It's now a third. One is called a frontalis sling, and that depends on how much motility you can get from the eyelid muscle itself. If it's not working very well, if it's very poor, the levator, if it's very poor, then we do a sling where you actually attach in a young child to be a silicone band to the upper eyelid and then to the brow. So when they lift that brow, the eyelid goes up. Another is called a frontalis flap, where they actually do a surgery and they move that. And sometimes you can go after the mular muscle or the levator muscle and you can resect that and pull it up. So a lot of times we're looking to see if there's a crease or if there are other things that can tell us what we're going to do to determine what type of surgery will be most effective to get the eyelid up. Ultimately, in a very young child, our goals are get the eyelid up, get it into good position, treat the amblyopia, and then afterwards, when the child is older, try and get things really symmetric for that cosmetic outcome. So, other things we can see I'm going to start from my young child going up is what we call a nasolacrimal duct obstruction. This is very common that we see in children. Studies have shown that it can be anywhere from 37 to 40 to 50%, depending on what literature you're reading in RTS. And it's characterized by tearing all the time. Sometimes it's there all the time. Sometimes it comes and goes, can be more associated with colds or upper respiratory illnesses where the sinuses are full, so everything reflux back up. Traditionally, we call it a blocked tear duct. A lot of children can spontaneously resolve by age of 12 months. So sometimes you see some surgeons will operate really early, prior to 3 months of life. And in that time period, you can oftentimes do the surgery awake, avoid anesthesia, get it done quickly. If you've missed that window, it's harder in an awake child to do that. So we'll sometimes wait till they're older than the age of 1, giving them time to get past when we know that, majority of patients resolve, and then also giving a child the opportunity to be able to tolerate anesthesia better. The one thing we worry about is a superimposed infection. So just imagine any body of water, or in this case, chairs that is sitting and collecting can get infected. And then sometimes those can become surgical emergencies. So if it doesn't resolve on its own, we can go in surgically in terms of treatment to do what we call a probing and irrigation, go through that tear duct, which didn't fully open, and open it. And sometimes that's a quick procedure, which we also can do early in life in clinic. If the child is older, traditionally anything past 18 months of life, we go in and we put the probe in, we make sure we can open the system, but then we leave a silicone tube in. In other children with craniofacial changes, even prior to 18 months of life, we will leave the silicone tube in place because we worry about the risk of recurrence when you're balancing the anesthesia risk versus that. So imagine you've got this tube and it's closed and perforated. You go in, you open it up, but its natural state is sometimes to stenose or to close back down. So what we do is we go in, we put a silicone tube in place that is sitting in there so that even if things try to close, there's physically something in that space stopping that. And that can typically sit in place from anywhere from 3 to 6 months is our preference here at Cincinnati Children's. And oftentimes most of us put those in, I particularly am one of them, in such a manner that we can take them out in the clinic without needing another anesthesia exposure. A common finding in RTS is strabismus. So strabismus means a misalignment of the eyes, either drifting out, eyes turning inwards, one up or down, or sometimes you can get a torsional component to the strabismus, which is often not as common. So sometimes when you look at a child, you try to determine, is that eye truly out of alignment? Or is that a pseudostrabismus, which is one of the things we do in the eye exam, try to determine, is a strabismus there all the time? Is it there some of the time? Or is it even a true strabismus? Or do I have a little bit of an optical illusion that makes me think there is a misalignment when there truly is not a misalignment? Because ultimately what we're looking at with the eyes, we're looking to see where the optical centers are, which is where you're using for good vision. And so and I'll show you some pictures. So this is a child who's got an esotropia, which is a turning inwards of the eye. As you can tell, you can't see the white of the eye there, but that's not really what we use. We would be looking to see where the light reflex is. And in this case, this eye is the eye that is fixing, or the eye the child is using at this time. And this eye is the one that is out of alignment. And you can tell the light reflex is not in the same position, so it's not symmetric. So that's another way we can tell. We don't always look at how much white of the eye we see, even though that is very commonly done. This child has an exotropia, which is a drifting outwards of the eye. And as you can see here, the eye is deviated outwards in that right eye. And if you look again, here is the light reflex. And here the light reflex, this is the pupil off center, letting you again know that the child is out of alignment. I did not put photos in of hypotropia because those are not as common, but they do occur. Now I put this photo in because this is a child with a pseudo-esotropia. So when you look at this child and you think, oh, I don't see as much white of the eye, I think the eye's out of alignment, very considerably concerning that it looks as the same as an esotropia. However, what we are looking at here, and this child has epicanthal folds, which we spoke about earlier, can be seen in RTS. But what I look at in this photo is I'm looking at the light reflex, since this patient is not in front of me, and it's pretty symmetric and right in the middle. So sometimes we will see some patients with facial changes, epicanthal folds, who it can be concerning that there is a strabismus when indeed there's not a true strabismus, and we do have to do a good exam in order to determine what that is. So in children, since unlike adults who sometimes will sit in a good position for you, you have to meet a child where he or she is. And so what we'll typically do is really make sure we've got the child's attention, either with a toy or with a particular movie they enjoy, or a parent's face or something very familiar. And if I imagine that this eye is the one that is fixating and not out of alignment, I would actually cover that eye. And I would do two things. I would look to see what happens to the eye I feel is out of alignment. So if that eye was out, I would watch to see if he moves in to look at whatever it is that we were using as a fixation toy. And then when I removed my hand or my occlusion paddle, I would look to see what happened to the eye I covered to see if it moved. And that would give me an idea of whether or not there was a true misalignment. So in this child with a pseudoesotropia, if you did what we call a cover test, you would find in clinic that the eyes would not move, even though the eyes do appear to give the appearance of an esotropia. So there are multiple ways we can treat strabismus. One of them is glasses, because in some cases of strabismus, what is driving it is the fact that the eyes don't see well. So the eyes are either pulling in or drifting out in order to get that very fine fixation. And so a complete eye exam, which we'll talk about later, will give us an idea as to whether or not glasses can fix this. Another thing we can do after we've treated any amblyopia and ascertain that there's no refractive error and make sure there's nothing else in the eye that is driving the process would be surgery. And that really depends on what type of misalignment we're seeing. So as you can imagine, there are muscles that move our eyes in and muscles that move our eyes out. And we then determine what type of surgery to do based upon what direction the eyes are misaligned in. One finding that is often discussed with RTS is glaucoma. And this is one thing that I know a lot of my families are very concerned about. A, because it's not necessarily something that a parent can easily see. B, also because the ways we can diagnose it or check for it are not easily obtained in children in our clinic. So glaucoma, and I'll just particularly talk about the types we find in RTS, is a process, a disease process by which you've got elevated intraocular pressures. And if you can remember going back to that image of the eye very much in the beginning where the eye looks like a little bit of a ball and there's the optic nerve and the optic nerve goes out and goes to the brain. But if the intraocular pressure inside the eye is so high, and everybody's level of what is high can be varying, but there are general parameters within which we know most people fall within, it can actually damage the optic nerve, and the optic nerve is nerve fiber, is nerve tissue, and we know that if you put too much pressure on a nerve, you can end up damaging it, and if you damage it, then the optic nerve, which is the cable that connects the eyes to the brain, starts losing all its components and it cannot send that information to the brain. And then there can be vision loss. The congenital type, the classic type that you hear about, and parents sometimes will come in and say, you know, my child has a lot of light sensitivity, their eyes are tearing a lot, and they're blinking a lot, is the classic triad we think of when we think of congenital glaucoma. I put the congenital in parentheses because glaucoma can happen at any period of time over the course of a human's life. And sometimes this diagnosis can be clinical, not necessarily something you find at home. And it's a lot of times based upon the measurements of the intraocular pressure or the IOP. In general, measuring the IOP in children is not easy. It always requires contact with the eye, and for the adults who may go see their local optometrist and may get the puff of air, while there is no true contact with the puff of air, that air is still touching the eye. And I'm sure you can imagine that can be very distressing for a child. Other ways we measure it do require the use of eye drops, which always sting and very distressing for a child. And sometimes if we're not able to get the pressure in clinic, then we may need to put a child under anesthesia for what we call an examination under anesthesia. I'm going to pause now and say that in the last decade and a half, there's been a new instrument called the eye care, which has really helped us because it does not require eye drops in order for us to check a pressure. It does make contact with the eye, although the child really doesn't feel it. And for the majority of our patients, it's become a great tool because we can avoid anesthesia, we can avoid drops, but we still have to get very close to the patient in order to use this instrument. That being said, it's taking away the need for a lot of examination under anesthesias, and it's also taking away the need for those eye drops. Because oftentimes, once you've put an eye drop in a child, you then lose that trust with the child, and then they may not let you do anything else. So the ways we treat glaucoma are typically two. One, we do a number of eye drops, and the goal of the eye drops is to change the physiology in the eye. And in glaucoma, we have too much fluid in the eye, so the pressure is high. So our job is to try and decrease that pressure. And so if we're able to give drops that are safe, not every drop for glaucoma is safe in children. There are some we cannot use in children of a certain age because of the effects they can have. If we can use drops to bring the pressure down, then we're generally happy. A typical congenital glaucoma that occurs prior to age 1 generally needs surgical intervention. And the goal of surgery is to then go in and to open the natural drainage channel in the eye. if that is possible. And if that is not possible, then create a new drainage pathway. And in children, we typically insert a glaucoma drainage device in order to help us. Sometimes you can create another drainage pathway by creating a hole in the wall of the eye and covering it with conjunctiva. The worry about doing such a thing in a young child is children rub their eyes, they're typically very active, and it's knowing that you've essentially left an opening in the wall of the eye that can, God forbid, lead to infections in the future. That is why we typically don't do that in children, but you see it done typically in adults. Another thing that can happen in Rubinstein-Taybi syndrome, not as common, but has been documented and can happen, is a cataract. So if you remember to that anatomy, we talked about the lens of the eye, and that really helps us focus. So the lens in the eye can become opacified for different reasons. Sometimes it's because of trauma. Sometimes it's because there are anatomic changes already in the eye itself that led to that. And sometimes it can be for other reasons, and then those can come on. Sometimes it's systemic medicines, such as steroids, that can change it, or really big fluctuations of blood sugar in the body that can change that and opacify the lens. Again, like we said, they're variable reports. It can be right there at birth. It can develop, which can come later, or you can get it acquired. One of the things I'm sure you've noticed with patients with RTS is they've got these beautiful long eyelashes. Long eyelashes are they're just absolutely beautiful, but sometimes they can get into the eye. And if they do in some children or in all of us, we would rub. The worry with RTS is that sometimes you can get into a cycle of a repeated behavior. Sometimes you would have started with just that initial irritation, but then it can just become a learned behavior that goes over and over and over. And with repeated rubbing or repeated learned responses of rubbing, that can actually lead to cataract formation, which can then block the vision and limit what people see or what a child sees. And in RTS, sometimes as the eyes form in, it doesn't form properly. So the eye itself may be smaller. And if the eye is smaller, all the anatomic structures in it too can be smaller. And so you can see cataracts more commonly in that setting. One of the things we always make sure we do is get a very good look at the back of the eye. So the last, I believe, anatomic photo I showed the optic nerve, the fovea, and then the blood vessels. And we really want to make sure there are no macular changes. Going back to that Dutch paper and going back to other scattered papers, some papers have found that you can get retinal changes. So typically when you look into the back of the eye, there's this beautiful sheen you see with children, and you get this generally orange glow, which is what a lot of cameras now talk about taking the red eye off, because that's the reflection of the retina back out to us. However, in some patients with RTS, that foveal reflex is absent, which makes us concerned about how well they would see if that area of fine focus is anatomically altered or altered with pigment or has coloration that it's typically not supposed to be there. Colobomas have been reported in RTS, and what a coloboma is an incomplete closure of the eye. So embryologically, when the eye is closing, it closes from top to bottom, front to back. And typically the colobomas that have been reported in RTS have been associated with microphthalmos, that smaller eye, and also associated with the back. The big thing about colobomas is wherever they're located, the rest of the anatomic change for that eye or anatomic structures for that eye is not in place. So where there's a coloboma, it can affect vision because anatomically what was meant to be there doesn't develop. So if it ended up close to the fovea, then it's harder for a patient with a coloboma in that location to see. If it ends in the periphery, that area of the eye that's collecting information is not able to because that area stays blank. Also, it can anatomically alter how long the eye is or how altered the eye is, resulting in either high myopia or astigmatism. And when we talk about that area is missing, you can get this visual defect, field defect. So one big thing that a lot of my families have asked about over the years is, how do you figure out if my child needs glasses? And then how do you get a child to keep glasses on? So those are refractive errors. And really, you need a good eye exam in order to be able to determine this. And we need to do dilation, which is generally not the most favorite thing for my patients, because the drops have to go in, you're getting very close to the eyes, and unfortunately the drops sting just for a few seconds, but they still do. And if any of you remember what it was like as a child, everything felt like it went longer than it truly was as a child compared to us as adults. So we need to do what's called a cycloplegic refraction. And the reason we do is that natural lens we have in our eyes, it changes, it can accommodate. So that's why if you're not particularly over the age of 40, you can easily pick up a book and read it and it's in focus, look in distance and it's in focus. And then you notice your parents or your grandparents, they start putting things further and further away from them, or they have reading glasses. Because as we get older, our ability to accommodate dramatically declines and in some cases goes away. That's why you need something for up close. But children have a lot of accommodative range. And when they do, what they're able to do is they are able to really bring things in focus. So sometimes they can do that well, and they can do that for periodic periods of time. So even our parents don't notice that things may be out of focus for a child. But the cycloplegic refraction takes away that ability to accommodate, so then the child really can't pull things in and out of focus, and it gives us the ability to really be able to measure how much refractive error the eye has, and then determine if the child needs glasses or if the child doesn't need glasses. You hear us say myopia, which means people are nearsighted, they see better up close, and far away is really out of focus. Hyperopia means you see better far away, and up close is harder to see without some correction. And astigmatism is based upon how things are bent. So I always give the analogy of an American football. So imagine if you're holding it and this is the long way and this is the shorter way. How our eyes see is light rays come in and they go past the cornea and through the lens and they focus on the retina. If you are, if you have astigmatism and the light rays coming in through this end, it's going to travel a shorter distance than if it's coming that way on the football. And so what you're getting on your retina is not that it's out of focus, like in nearsightedness or farsightedness, it's just that it's blurry. And sometimes you see a child really bend their head or close an eye or squint really hard in order to bring things in focus if they've got any of those refractive errors. But really, the astigmatism is the one you see sort of like this very interesting head turn, because they're trying to find like that axis where maybe all those light rays align and then they can actually see whatever it is they're looking at very well. In terms of glasses wear, you really need properly fitting glasses. So I wouldn't recommend anything like what I have on for a child because those are easily breakable, and so that's a safety concern. I prefer breakage resistant glasses. So a lot of glasses are on the market and they're very bendable and flexible. In those circumstances, if they're very bendable, what happens is the lenses can pop out. So as a parent, you're now trying to figure out, well, what's left, what's right, what goes where. But shatterproof lenses are preferable because then if they pop out, they're not breaking and so hopefully not injuring the child. Glasses can be very sensory and can provide such a sensory loop, and some patients are not able to tolerate them. And some children, like I said, can have that high accommodation range that it takes them a really long time to get comfortable with the glasses because they're so used to just pulling in and out their own focus that they don't want to stay in the glasses. But the disadvantage to pulling in and out their own focus is sometimes then you can see a strabismus, especially a child who's really farsighted, who pulls in his or her focus can turn their eyes way in. And then you really want to give them their glasses so they see well, so they can relax that and keep their eyes straight. And the last thing is if we have a child who's typically not wearing their glasses and really needs it, remember we said the eyes are sending information to the brain and the brain is learning to see. So if you're not giving that child the right thing early enough and giving them that clear vision, they could grow up and then maybe take a child who needs glasses at age 4, didn't wear them or couldn't tolerate them or didn't know they needed them, parents didn't know or the caregivers didn't know, and got glasses at age 8. Sometimes the brain has just learned that blurry is the normal, and even if you correct things, things will get better, but you may never get them back to that perfect clarity, we would all hope for. So there are other options for correcting refractive errors, especially if the sensory concerns are too high or the glasses prescription is really, 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 really high and not easily placed into glasses or not easily tolerated. One thing we use a lot in our practice are contact lenses, provided it's tolerable for the child for them to go in and out. And we actually follow very closely to make sure we don't result in any infections or any other complications if we go that route. I put an asterisk here, refractive surgery, because it's not something we do in pediatrics, but in adults you can see it. Corneal refractive surgery, your LASIK surgery, your PRK surgery, all of that you hear the adults do. We don't do those in children. There are a few in the United States FDA exemptions for children who are very intolerant of anything sensory. And there are a few centers in the United States who will actually do these in children under a compassionate use, where you've tried everything else and you really need to get this child to see well, and for different reasons, they're not able to tolerate every other option. The concern for doing corneal refractive surgery is the fact that the eye is growing and as a child grows. So whatever you do, let's say at age 0.7 or age 6 or 5, the eye is going to keep growing. And so if you correct them to perfect at age 6 and they're still growing, then, they're great at 6, but then what happens when they're 10 or in the future if they're still not wearing the glasses, which is why even adults you hear would say the earliest we'll do is 18 if we're certain that your refractive error isn't changing. In some other patients, particularly those with very, very high myopia, some places are putting in lenses, so taking out the natural lens and putting in a new lens. And in that case, then decreasing that high refractive error. And some other places are doing what we call pseudophakic intraocular lens placement. So keeping the natural lens in there and then putting another artificial lens over it, provided it doesn't touch the lens and irritate it, to decrease that refractive error. Those are being done a little bit in the United States. Again, not typical in children, but they're definitely being done internationally. So I wanted to make sure I added that to this, because those are options, especially if you really need to correct a refractive error. Keeping track of time. So what do we do in the ophthalmic exam that is really important? The first thing a lot of us do, we just watch a child, sometimes just observing a child to give you an idea about whether or not they see and how they see. Well, Lauren, I want you to just do a good temperature check before we go into this half of things, if there are any questions I can answer and how everybody's doing.
Yeah, I think it's going great with the time, and we have a couple questions in the chat that were kind of based on what you were presenting about. So Chantal was asking, at what point would you do surgery for strabismus? We've seen 2 ophthalmologists in the last 2 years who have conflicting ideas. One says it's just aesthetic and would make no difference to his vision. The other that would show that we should try to align them, but to know that we will likely have to repeat the surgery in 20 years or so.
So thank you so much for that question. I think part of it depends on what you're seeing. So typically, if the eyes are turning inwards and there's no glasses help to that, it's not a child who's very farsighted, typically then we proceed with surgery. If the eyes are turning outwards, if it's permanently out there, you can proceed with surgery, but there's another type of strabismus called an intermittent exotropia, which is sometimes the eyes are straight, sometimes they're out, and it can be very variable. In patients with that type of strabismus, sometimes we wait because we know it comes back, and we wait until what we term control, until that gets really poor. Because we know it's going to come back. So there's nothing more disheartening than doing a surgery and knowing that, okay, yes, it's going to come right back, which we know the high rate of recurrence is really high in that particular type of strabismus, and then having to take a 2-year-old, when you do your first surgery, back to surgery at age 3, especially if the control was fair. So not knowing the specifics of what the strabismus was, that plays a role. And also, I think the first ophthalmologist said the vision wouldn't change the vision. So the question becomes, is the eye anatomically healthy, or is there anything else in the eye itself, like a coloboma or retinal change, that's causing the eye to not stay in focus? And if they feel that that's the case, then strabismus surgery may be more of a social concern. So in those patients, I may wait till they're more school age, where I know that their peer group may influence how they feel, and do surgery, knowing that the alignment isn't for vision, but is more to make sure that they can progress in school or progress in their social peer groups. I hope I answered all the questions you were asking. If not, please put more in. Lauren, what was our other question?
So this question from Beatrix and Sam, she was asking, when you are doing an eye exam under anesthesia, do you ever combine that with other surgeries to reduce the need for multiple sedations?
Absolutely, we do. So thank you so much for that question. I was going to get to that, but thank you for bringing it in. So one of the things that we we do very well here at Cincinnati Children's, and I'm going to say a lot of other pediatric-based hospitals do, is we combine a lot of cases together. We don't always combine with imaging like MRI, because the MRI, we can take magnetic things into that space, and everything we use in surgery is mostly magnetic, but we do combine with other surgical procedures. So oftentimes a lot of my patients with RTS or other patients going under anesthesia, you see where we're multiple surgeons in the room doing different parts of things. So many moving parts, but our team has gotten very adept at making sure we can get everybody we need in the room, even including things as simple as getting their blood draw for their routine labs, or getting an EKG, or getting a hearing test, or even putting in a cast, or getting a mold for their hearing aids. As many things as we can do while a child is under anesthesia and safely we do try to do that.
Thank you. So this question is from Sarah. She says, for a child with severe amblyopia who will no longer tolerate patching, do you recommend using atropine drops? We've tried this multiple times, but get mixed opinions.
Yes. So there are two other things outside of atropine that you can try for amblyopia. One is newer and was just FDA approved in 2024 in the United States. You can try atropine, but it has to be if the vision is to a certain level. So what atropine does is it blurs the vision, and the idea is if you blur the right eye, you're going to force the left eye to see well. However, if the left eye sees poorly, and you blur the right eye, but it still sees better than the left eye, then it's not really worth it, because the child will still use the better seeing eye in that case. So the idea of the atropine is you blur one eye so it sees poorer than the other eye that doesn't see as well. So the child starts using that. So that level of amblyopia would really determine whether or not atropine will be helpful. There's a new thing called luminopia. The different versions is another one that has been FDA cleared, but as of my last check in April, not yet FDA approved. And the idea of those is you keep the child binocular, so they're using both eyes open. In the luminopia, which is the FDA approved and the one that we have available currently at Cincinnati Children's, they're wearing a VR headset. They get to watch, a movie. And what happens is, let's say the right eye is the amblyopic eye and the left eye is the stronger eye. The image that is actually being presented to the left eye will actually be degraded. However, the child can't tell the difference when they're watching with both eyes. And what happens in that setting, since both eyes are open, they're actually going to strengthen the poorer eye because the other eye is being degraded. And they have to keep that on. So again, you have to make sure that they can tolerate that sensory feel of that VR headset on their heads, but they keep that on for an hour a day for 6 days a week. And so those are different options. So the level of the amblyopia is really the key driver. And that's why we talk about doing exams really early. So hopefully if we have amblyopia, we can catch it early and hopefully treat it, because patching can be pretty distressing to children. It is effective though, but it can be distressing.
Our next question is from an individual with RTS2, and they're 45 years old now, and they were diagnosed at age 8 with macular pigmentation. They wanted to know that the imaging every year hasn't changed, but is it possible for that to change in the future?
So, a lot of the data that we have on that suggests that that is very static. The one that comes to RTS you look in there, it was there already at birth. There's some studies that talk about doing an electroretinogram, an ERG, or visual evoked potential to check for that. So a lot of the studies are suggestive that once that's there, it stays. That being said, since you are older, you still want to continue to go in yearly or every 6 months, depends on whatever your ophthalmologist has recommended for all the testing. Because for all of us, as we get older, there are other retinal diseases or other retinal changes that can show up. And what you don't want to do is make the assumption it's just secondary to RTS. If there could be a secondary process that is independent of RTS, maybe layered on top of what you're seeing with RTS, but that could potentially be treated. So that's not missed. And so you're not sacrificing vision in that setting.
Excellent. And our next question is from Beatrix and Sam. They're wondering, do you have an idea of what age is it safe or feasible to have kids wear contact lenses instead of glasses?
Yes, so that is a little bit of a nuanced question. The reason I say that is babies with congenital cataracts, which we talked about a little bit as early as 4 to 6 weeks, I'm putting a contact lens in them. But the type of contact we're putting in them actually is more breathable. It's more of a hard contact, so the risk of infection is lower. And in that setting, the parents are monitoring versus the more common contacts we have, which are more silicone, have a higher risk of infection. So traditionally, I wait till a child is 13 and I really make sure that they're very good to put them in the traditional contacts. That being said, we make exceptions across the board because if there's a big refractive error, glasses are not tolerated. I'd rather do contacts with parental oversight or caregiver oversight to make sure I get good vision rather than keep pushing glasses if that's not working. So I do think that it depends on how big the refractive error is, what you need to get it for. It may be possible. And I've had patients who don't necessarily have a big refractive error, but the sensory need from glasses is too high that we have switched to doing contacts. So it can be very individualized. I would recommend that you partner well with your ophthalmologist. In our group here, Practice at Cincinnati Children's, we actually have pediatric optometry in our practice that is intertwined with us. So they also help us with that. And so we oftentimes will have combined clinics where they'll come see the ophthalmologist. And just because of access and other things in our practice, we've let our optometry help us with the contacts, but then somebody's always getting oversight. So even if I don't personally see your child every 3 months, I know there's a touch point somewhere. So we're making sure that it's safe and not creating a secondary problem.
Great, thank you. And I think in response to your last question, Sarah had asked if lens surgery could replace glasses and contacts.
So yes, that was what I was saying. That lens surgery can. So typically, we do not do that typically in children just to replace glasses or contacts, just because after cataract surgery in younger children, you have a risk of glaucoma, there's a risk of retinal detachment, there's a risk of infection, and the postoperative course is pretty complex with eye drops sometimes, oftentimes 6 to 8 times a day. So we would only make that exception if there was absolutely a clouding of the lens, if there was a high refractive error. Only in those circumstances do we do, and that's why I put that asterisk when I got to that. Typically, the other thing with lenses is the lenses are available right now, oftentimes for children, correct you for one distance. So we can make you perfect in the distance or make you perfect at near, but we don't have a lot of lenses that make you perfect everywhere. There are lenses out there in the adult world that make you pretty close, not quite perfect, but pretty close in those places, but they're an upcharge, not covered by insurance. And so there's a relatively high out-of-pocket additional cost to an adult patient who chooses to use one of those lenses. The lenses have gotten better. So what happens is if I put a lens in a child now, I know that I can get them great for distance, but they'll still need something up close to read with. So if we're doing those to avoid glasses, we're very careful to understand, what the risks and benefits are in that setting.
Thank you. Those are all the questions that we have. Thank you, everybody, for your thoughtful questions and for your wonderful responses. I think we're ready to move on with your presentation.
Wonderful. Looking at the time. So what do we do in the exam? We take a really good look, and sometimes just by looking at the patient, I can tell if they've got a strabismus or if they have an intimate exotropia that may not be there all the time, or if they're squinting one eye over the other, or if they can't see. I've walked into a room and, met with a child who was really terrified, and it just happened to be that they were really high myope, could not see anything. And once we gave this child glasses, the next visit, completely new attitude, happy, engaged. So those are some things we can get the information on. Really looking at the ocular alignment before we do any type of drops or before we put any patch on, because sometimes eyes can look really aligned and you cover one eye, you can bring out a strabismus. And so looking at how the eye muscles are moving, because that gives us an idea of what we'll find. Listening to our parents or our caregivers who spend more time with our patients, then getting a vision. And really, there are many ways we can get it in pre-verbal children. We're just watching to see what they do with toys. We can use what we call an OKN drum. We can use teller acuity cards. And as a child gets older, we'll start with shapes and we'll gradually move on to, letters or whatever they're comfortable with. Looking at the pupils to make sure there's nothing going on. We don't see any pupillary changes that are suggestive of something happening within the eye or something happening along the visual axis pathway, which includes the brain. And I said plus minus to the anterior segment examination because that's looking at the cornea, the lens. We have to get really close to do that, and some of our equipment can be overwhelming for our patients. So sometimes we find other ways to do that. Then we do the dilation, and you have to wait 30 minutes in order to take away all that accommodation. So you can imagine you've already come in, you've done all of this. Now you have to wait 30 minutes, and that's a really long time for anyone, especially a child, to wait. And then coming back, and then we take a really good look at the retinas, looking at the optic nerve, the macula, and looking in the periphery if we're able to get out there, and then checking that refraction. Because once you've taken away the accommodation, our instruments and our lenses can help us determine, are you farsighted? Are you nearsighted? Do you have astigmatism? And how much do you have to determine whether or not you do need glasses or whether or not you don't need glasses? So, functional vision, I'm going to try and move quickly because I'm looking at the time now, or almost back on the hour. One of the things we're also looking at with outside of just looking at the eyes, the visual fields. Some people can have really good central vision, but they're missing everything around them. So they get up to walk around a room or ambulate, and they may bump into you, bump into a wall, because that's missing. So we do need to make sure we're paying attention to that. Can you see contrast, or is your contrast sensitivity low? So it's better not to give you, a pink rose on top of, a tray of orange or something because you can't see the separation. It's better that I give you, I put your black plate of food on a white table, or I put black letters on a white sheet so you can see it. Or in classrooms, some of my patients would tell me they've got a screen, no longer a blackboard, and the teacher writes with a yellow marker and they can't see it because there's not enough contrast for them to be able to separate that too. Looking at the visual acuity, is that one eye that's preferred over the other? I know some people were asking about amblyopia earlier. Looking to see if there's any wiggling or shaking of the eye, which is nystagmus, which is suggestive of something along the visual pathway that is limiting vision. And then looking for the misalignment of strabismus, because that really affects how we use all the vision we have, not just how well we can see reading the eye chart. Again, the ocular examination, but I always tell my families what I see in exam does not always dictate what the functional vision is going to be. It can predict to a certain extent, but I've been very surprised. So if I get a child and the first time I met them was only under anesthesia, I'm cautious about how I interpret what I see until I really see the patient in their environment functioning for me to be able to say, yes, they'll see well, or God forbid otherwise. Again, getting that refraction and then really paying attention to other things that is present, because there's a process called cortical visual impairment where I may look in the eyes and I can tell that the eye structurally can collect the information. However, interacting, you can tell that the child is in processing or the adult is in processing. And that's cortical visual impairment because the brain is really what interprets what we see and really putting that into context. We break it down into ranges. If there's minimal response or if you spontaneously use it, or if it's more consistent, if you've seen something you've seen over and over again, can use it for function, or do you need a little bit more help to interpret what you see? There are 3 phases for CVI that's how we use it. There are different scales that are used, but in phase 1, you really want to build consistent visual behaviors. Going back to what we talked about, that as our eyes continue to learn as we grow, so really building that and just getting, early therapies and reminders that this is how you see. Then how do you integrate seeing this with how you use it, and really then in phase 3 demonstrating visual curiosity consistently and being able to put all those pieces together to use your vision spontaneously in visual tasks. So big things you can see that are suggestive of cortical visual impairment. However, you do need to see an ophthalmologist for diagnosis. A child may prefer colors. Oftentimes really, really bright colors may be more preferable to duller colors because it's easier to perceive. Something needs to be moving before you get a response versus if it's just stationary, because they may not process that is there. Sometimes there's latency where you introduce something and you wait, and then it seems like, now they see it, or they may ignore a certain part of their visual field, or if things are just too complex, you can see some children shut down. That's why sometimes we'll say, find a black felt, put one thing on it, and then once you're sure that consistently there's response, you can add other things to it. But if it's very, very busy, it's just too much. There's so much visual crowding in the space. Or even in the classroom, where sometimes I have patients who come in and say, this is this is my homework. And I'll say, well, that's too crowded for you. We really need you really need teacher to separate it, so then you can realize, oh, this question is 3 + 2 is 5. If I verbally ask the patient can see, but if it's on a line and there are multiple questions, everything sort of is too much. And sometimes some of my patients just can't process all of that. It's just coming too much. Sometimes you see a patient who does well up close, but they'll have difficulty with distance. They won't have typical visual reflex response because then their processing speed is delayed, so that reflex may not be there, or they'll respond very well to a mom's face or dad's face or caregiver, but not to a new face, and just have other visual motor delays. So it really depends on the phase, and it's really targeted. We work very closely with our occupational therapists here who are trained in CVI, and also with our medical doctors. We do have a CVI clinic now at Cincinnati Children's. The other thing I wanted to quickly touch on before we get to, we're getting close to the hour, I think 3 more minutes to that hour, is low vision. Sometimes, despite everything we do and despite everything we want, sometimes we don't get that optimal vision that we want. However, that's not, in my opinion, that's not a stamp that you can't do everything you want to do. That just means we need to work differently. And we have a low vision clinic now at Cincinnati Children's, and they work really great. Sometimes it's just spectacles, sometimes it's bifocals, sometimes it's bionics, sometimes it's even collapsing large angle strabismus, sometimes it's magnifiers or video device. Now we're in the world of electronics, your tablets, your iPads, all of those that are very adaptive to use are great because then a child can manipulate them. Some of my patients say, I just use my iPad in school. I can't see what the teacher writes on the board. I hold it up, I zoom it in, and I take a photo, and then I can see, oh, she wrote a 3 + 2 or whatever it may be. And sometimes it's just telescopic devices where if they're in a crowded space, they can look up, go around. Oh, that's my mom. I know I need to head in that general direction to find her. When I get closer, I'm clear enough to be able to say, hey, mom, this is where I am. I need help, or whatever it may be. And this is just a photo from an organization that's just showing a patient, not with RTS, but with another visual limitation, who's using a magnifier in order to be able to read, her book. We work very closely and we recommend orientation mobility, because even just getting through a classroom from classroom A to classroom B, and sometimes some of my patients who I know don't have optimal vision the way we have, but maybe can ambulate around in their homes, I'll have them use a cane in school. Not necessarily for them, because I know they can maybe see enough to get 2-3 feet in front of them to get the next 2 to 3 feet, but for everybody else around them to be very careful of them so they don't trip them up, make them fall or something else. Really advocating for our IEPs in school and really making sure you have either a teacher for visual impairment or somebody who really says, the IEP for Jane is not going to be the same IEP you give Sam or whoever that may be. That's why it's individualized. Sometimes the schools can get overwhelmed and try to lump people together, but we're not all the same. Again, using that technology, sometimes if we need it, bringing in Braille. And sometimes I think of Braille as, and I speak multiple languages, so I use that analogy as maybe a second language where if things get more complex, it's faster for a patient with some level of visual impairment to read Braille than to maybe use a magnifier and have to move it and to get through that whole paragraph if they can just read it and get through it quickly. So it's the second language they pull out if they needed it in that circumstance to get around. And I'm going to end here because I'm right on the hour and I'm glad I got through. I'm sorry I went quickly at the end. I really wanted to honor the time, and we started at 7:02 and it's 8:02. Thank you all again.
Thank you so much. That was incredible timing, like you said. We do have a couple questions in the chat, and I'm sure folks will have more to ask as we continue. But we have a question from Yabin, and he says that his 3-year-old daughter had strabismus surgery for worsening bilateral intermittent exotropia. Initially, her eyes aligned perfectly, but 1 month after the surgery, she started to have right eye intermittent exotropia again, more obvious when she is looking up. At what point should we consider surgery again?
Yeah, and thank you so much for your question. So actually, I know somebody asked another strabismus question. So intermittent exotropia is one of the strabismus surgeries that come back, and it can be very disappointing for everybody, surgeons included. But we know that that is the natural history of that process. I would say that the next time to consider it is depending on how often you're seeing it, how poor is the control. On average, most people with an intimate exotropia get two, and depends on who you read, 2 to 2.5 surgeries over the course of their lives. So the question becomes how poor it is. If it's something you only see when, it's end of the day, your daughter is tired, but throughout the day you see it infrequently, I would wait. If it's, one of the good questions we ask in clinic, and I generally pick a Saturday because most people work and not able to stay home all day with their children. So if you're home with her all day Saturday, do you see more than half of the time you spend with her Saturday or Sunday? And if the answer is yes, then sometimes we tend to think maybe we need to do something sooner than later. The other questions I would pose to your ophthalmologist in this setting is one of the things we can do for an intimate exotropia is what we call over minus glasses. So provided your daughter is not yet nearsighted, and can tolerate glasses and doesn't, then we would give over minus glasses because that when you look through stronger lenses, it forces your eyes to come in, and that buys you time. It's not curative, but it could buy more time. The difficulty with this in a young child is she's not going to see any differently with them on or not. She's going to do this and she's going to do that and realize, well, I see the same, right? But when she wears them, she actually has to use accommodation to pull her eyes in to use them. And that may be able to buy you 1 to 2 to 3 years. And studies have demonstrated it pushes out the time to surgery. If she's already nearsighted, I will not recommend it because we do know that if you already are nearsighted and you do over minus lenses, you end up making nearsightedness worse. So you don't want to create a different problem trying to fix one.
You. Katie has asked that her daughter's almost 2 and she will often rock her head back and forth. The physical therapist is concerned that this is vision related. She has colobomas and wears glasses. Is that often seen as a side effect of having vision impairment? And is there anything that you would recommend?
So thank you, Katie, for your question. I think that it can come from eyes, but it can also come from other things. So having not knowing where her colobomas are and not knowing when she's stemmed. So if she's stemming every time you give her a visual task, the question becomes, is she stemming because she cannot see it, or is she stemming because it may be overwhelming or an avoidance for other reasons. So in this case, I would work with an ophthalmologist to know where the colobomas are. Yes, stemming can be just because visually a child isn't seeing well, and it could be an outward sign of frustration that cannot be verbalized, but it could also be secondary to other things. The other thing I would want to know is if the stamen is a relationship to some frustration, do we have a way to redirect that to do something else so that she isn't doing that particular response? I could be wrong. That may be the only response she's able to. And then the last thing is oftentimes I will work with my developmental pediatrician to see if we can work together to address this. But to answer the question, it could potentially be from that, but to say it is 100% would be incorrect of me to say.
Thank you. Michelle was asking at her last visit, the doctor noted 2 items, dandruff on the eyelid, which also might be eczema, which is resulting in a lot of eye rubbing and just recommended to wipe with a warm cloth. Have you seen this with RTS? And she wasn't sure if it is something more serious going on with the eyes. And she also had a second question I can read and then remind you. The second item noted was a little bit of cross-eyed. Does that fall into some of the other conditions you mentioned?
So to answer your first question, yes, if you remember, we talked about that RTS have these beautiful eyelashes. Along those lines, you can also get what I'm understanding when they use the word dandruff as blepharitis. You can see that in RTS and you can see that independent of RTS. And that's just a buildup on the lashes. You can see a patient with eczema or atopy or skin changes. And sometimes we can see it independent of that too. The primary treatment of that is lid scrubs. So, talking about the warm cloth, yes, but if there's a buildup on there, we talk about either trying baby shampoo, no tears formula, because you don't want anything going into the eyes that would irritate. There are some commercially available products out there as well, and I'm happy to get that information of the ones out there to Lauren that you can try to really clean the eyelashes off to get that debris off. I would also want you to post your ophthalmologist and to ask them that is it just blepharitis. Some subforms of blepharitis may actually be caused by other bacteria or other microbes that we do need to target treatment. And without taking a look at the eyelashes to see what it looks like, I wouldn't be able to tell. But most of them is not. And typically the warm compresses and lid scrubs should help you get rid of that. Now for your second question of cross-eyes, yes, strabismus or cross-eyed esotropia in that particular case is very can be typical with RTS, depending on what literature you read, anywhere from 57 to 70% of patients with RTS will have a strabismus. And so the question is it because there's a glasses need? If it's the eyes are turning in, we ask is the patient farsighted? Is that what's causing it? Making sure that there's nothing in the retina or the optic nerve that's causing it, and if it's just an acquired RTS, the question becomes acquired strabismus, sorry, not RTS. The question becomes, do you just need surgery in order to help align the eyes?
Thank you. The question from Sarah asks, after ptosis surgery with a silicone sling as an infant, do you see most kids need another surgery in the future?
Yes. So, Sarah, we oftentimes tell our parents that if you're getting surgery for ptosis as an infant, you're guaranteed to need another surgery when you get older, which is why when we were talking about it earlier, I said if I can get a child and I know that I can get them to still keep that eyelid high enough, we'll wait till they're a lot older to get it. But if the eyelid is too low, you need the surgery, but we know we always need another surgery when they're older. Oftentimes, if we can wait till they're 4 or 5 or 6, sometimes that may be the last surgery they need in life. Not guaranteed, but very common after the first one to need at least a second.
Thank you. Beatrix and Sam are asking, how often is sudden degeneration in vision a sign of a larger concern, like congenital glaucoma for children with RTS, versus the vision stagnating over time? Example, going from good vision to negative 8.5 within the span of a year.
A big change if there was a good cycloplegic refraction the year before from nothing to a -8 would make me concerned to make sure I get a good look in the retina. Um, Myopia can jump, but an 8.5 diopter is not typical. So I would really want to look in the retina to make sure there is no staphylomas or retinal changes or coloboma that would suddenly give me a big change. Um, and then if it really was the case, then I would be asking outside of RTS, is there something else going on? Some other retinal disease that is resulting in that. An 8.5 myopic shift is not typical. I would also want them to pay very close attention to the lens because if you've got big lenticular changes or corneal changes, that can do it. Now, in a very young child, if there is glaucoma, I have seen huge myopic shifts because the eye of a child is very elastic. So if the pressure is too high, you can get such a big change. But ideally, you should see other findings of glaucoma with that. But in those cases, those are one of the things in the back of my mind I would be asking myself to make sure wasn't contributing to such a big myopic shift.
Thank you. Lydia Boyce's mother is asking, or I'm just reading it wrong, sorry. My son is significantly farsighted. Lens number was over 4, but I don't remember exact details. My problem is that he absolutely refuses to wear his glasses. I can't get him to wear them at all. He gets just fine without them, but I'm concerned just never using his glasses will harm his eyesight. Are there any tips to help him tolerate his glasses? He really hates them. So several ophthalmologists had said he had strabismus, but when I took him to one that specialized in working with special needs children, he said my son crosses his eyes on purpose, especially up close.
Okay. So anything over 4 for a child typically over 3, age 3, we worry that will really blur the vision. And these are just, the American Academy of Pediatrics, American Association of Pediatric Ophthalmology, and Strabismus and American Academy of Ophthalmology. We've looked at it and we know what range for giving glasses, but typically we would say needs glasses. I would say that I would ask them if the cycloplegic refraction was accurate, with no offense to the doctor, because even if I have a child come back to me and they don't wear the glasses, sometimes I ask myself, did I get it right? Because if I've got a child who's moving, sometimes we're human, we don't get it right all the time. And if that's the case, then the question becomes, are the glasses made properly? Because sometimes they're not made properly at the optical centers where they're supposed to be. How do they fit? I don't like glasses that rub against lashes in children. That's very sensory. You want to make sure they're not pushing down on the ears. I typically like something with a little bit of an elastic band that keeps it in place. And if that still doesn't work, then I ask in my practice, I have my parents do dilating drops, which are not fun. So I'll have them, if I know a patient gets up at 7, I'll say go into his room or her room at 6:50. So 10 minutes for the wake up so you're not breaking the sleep cycle. Put the drop in, run out of the room. So when they wake, they don't see you coming, so they're anticipatory. But then when they wake up, their eyes are blurry. And so if you give them the glasses and they realize, oh, when I put these glasses on, I see well because now I'm blurry, as opposed to what your son is probably doing, which is he's pulling in focusing power, which his eyes are turning in, so he feels he doesn't need the glasses. In that circumstance, sometimes you may do the drops multiple times. Usually we do it for 5 days to break the ability to pull it in and hopefully show your child that the glasses are helpful for his vision.
Wonderful. Thank you. Jillian is asking, does Cincinnati Children's have a peds glaucoma specialist? Have you ever heard of a pediatric patient with an eye care home to help monitor eye pressure for glaucoma? My son was diagnosed at 11 months and is now 9, has had many surgeries and now doing laser and EUAs due to not able to get readings in the office.
Yes. So yes, we do have a number of people in our practice at Cincinnati Children's who do pediatric glaucoma. I medically manage it. I don't do the surgeries any longer because there are just a number of us. There are 3 in particular who still do the surgeries in our group, and I'm happy to share their names with Lauren for her to get those names directly to you. Yes, you can also do the eye care home. We actually did a study here where we gave those eye cares to our families to take home. And actually, happen to have been part of some of the eye care studies because where I trained was one of the first places in the United States that consistently used it. And we used to give not even the eye care home, we just give the standard eye care to our families to take home to use because it's easy and you can learn how to use it and do it. And that's a way to follow the pressure. No one particular way of checking pressure is perfect, but the IQ at least gives us an idea, provided the cornea is normal, so we're not getting false readings. So if we can get to a place where you have good readings and you can get readings all throughout the day, maybe you may be able to lessen the number of examinations under anesthesia you're having.
Great. Thank you very much. Well, we have about 10 minutes left if anyone has any questions while we have Dr. Desunmu on the line, but we're all caught up in the chat. We'll take a short moment to see if anything else pops up. Otherwise, Celia and I might wrap up. We have an announcement about some upcoming events, and then we will send out our survey. We would love to get some feedback about the presentation this evening. And please keep in mind, if you are interested in the meeting recording and the slides, you will have to complete the survey so I can get your email address and send that out. Beatrix and Sam are expressing their appreciation, as we all are. Thank you so much for answering all of these questions so
Thank you so much.
thoughtfully. Yeah, I think that I agree. All of the questions that people have been asking have been really, really helpful and really insightful. Let's
Thank you so
see.
much. I just actually saw the chat now, so I was reading it.
Yeah, lots to catch up on, lots of thank yous and appreciation. This has been really, really helpful. And Sarah is wondering, she might have missed this. Oh, I write, my daughter keeps poking herself in the eyes. Sarah, oh, is there more to that question? Dr. Dasunmu, is that something that you see frequently if someone with RTS is poking
Yes.
their eyes?
So we do, and we prefer to not do that. So you can have poking an eye because it's a learned behavior. It can be a STEM in behavior. I know we asked about a different type of STEM earlier. We really prefer that that's not the case because it can lead to corneal changes. It gives a lot of feedback, and so a lot of some children enjoy it, but it can lead to cataracts. And the most concerning thing is it can lead to retinal detachments, and those are particularly harder to fix in young children. And then especially if you fix them and the rubbing continues. So in those cases, we really try to figure out why it's happening, make sure there's nothing already in the eye that is causing it. So I would recommend you see your ophthalmologist. And then the second thing would be, in our case here, we work very closely with our developmental pediatricians to try and redirect that behavior to something else because of the potential damage to the eyes. And with good vision, if you keep rubbing, we don't want your daughter to lose her vision. So we need to make sure she isn't also trying to tell us that the eyes are uncomfortable, that there's a glaucoma, like somebody was asking earlier, or something else. So we really need to get a really good look. Or even, the things we didn't talk about because I focused really on RTS, but there's some really interesting things like just even allergies, especially this time of the year, can lead to rubbing and can cycle.
Mm, thank you. Michelle was wondering, her son has congenital glaucoma with many surgeries. He has 2 shunts in left and 1 in right. No vision in left anymore. Will his eyeball be okay?
Michelle, I'm so sorry that your son has less vision. That is especially hard. Um, If the surface of the eye is comfortable and the pressures are in a comfortable range and there's no vision, and your doctors have said there's nowhere to get vision back, there are 2 primary things I would recommend. I'd recommend that your son stays in glasses for protection. And I know that that could be sensory, not because the glasses would help the vision, but we really don't want anything to happen to the right eye that already has 2 shunts and is the only eye for seeing. We know that 40% of people who have one eye get a lot of injuries at home, also at other places, but in particular, they feel very comfortable at home, so that reflex to be a little bit more on guard isn't there. And sometimes you hear, oh, somebody called me, they're not seen on that end, they turn into something, and that's when injuries happen. So really developing that, and then making sure that the other eye just stays comfortable. Oftentimes we don't touch an eye only the time we would only recommend, doing something and I apologize to everybody in the chat, I'm just answering that question, like taking out the eye out is if the eye becomes uncomfortable. We wouldn't want an eye that doesn't see that is painful and causing more stress than not.
Great, thank you. Katie is asking, are you able to do consults with kids out of state? My daughter is super sensitive to sunlight. We use transition glasses, but is there any other treatment you recommend?
So yes, we're able to see children. Lauren, I think you have to help with that because it depends on where you are state-wise, but I know that the team here can help with coordinating that. Yes, and we also know that there are a subset of patients with RTS, and I didn't talk about this, who had photophobia. We know a lot of them do, and oftentimes we find something in the eye, glaucoma, something in the cornea, something in the retina, but there is another subset that despite all the testing, we found nothing going on that we could see from science. And I'm talking about studies. So when I use we, not necessarily me, but the ophthalmic community when we've looked at RTS, and we just know that there was photophobia there. But these are some studies long time ago. Maybe we have our machines could find it again. But there may be a chance that if she's had a good exam and they see nothing, but we do know that some RTS children will still have photophobia. In those cases, we talk about extra active transition lenses because especially if your daughter has lighter colored eyes, she may just have a lot of light that can get in. So your blue eyes, your hazel eyes, your green eyed children, and extra active transition lenses may be better because they get a whole lot darker, and that may give her a little bit more comfort. And then making sure there isn't any other thing in the retina, so no other nystagmus or no other retinal disease that could be leading to that.
Excellent. Thank you so much. We are all caught up on the questions, which is great to see. Again, all the questions have been really, really helpful and really insightful. Thank you so much for your presentation this evening. And I'm going to pass it over to Celia to share our upcoming events and our survey for this presentation.
Thanks, Lauren. First of all, I just want to thank you guys. This has been amazing. I can't tell you, it's been so interesting, and I want to compliment how simple you made this and understandable you made it. And I know our families are super appreciative of that. So thank you so much. If you guys will just hang on a couple more minutes, we wanted to share with you something exciting. As you see up on the screen, we are going to begin a RTS social group for young women. We're starting in this space because we were actually nudged and pushed by two siblings of individuals with RTS, one of whom spoke at our national conference 2 years ago, Rachel Weintraub, she's Abby's sister, and then Mary Poland, and Mary's sister, I believe, is Emily. Her name's escaping me right now, but they are siblings, and they had said something to us way back at the conference because there was a very strong group of young girls, young women who were very interested in continuing a conversation, and we just didn't have the ability to support it at that point. But we've worked hard, and Lauren's been doing such a great job, and she's been helping us facilitate a conversation. So we are going to start in June with a young women's social group. And Rachel and Mary are both occupation or speech therapists. Are they both speech, Lauren? Help me remember.
They're speech language pathologists.
Yes,
Mhm.
yes. So both of them have a background and just have a lot of knowledge. So we're really excited to see that get started. We don't know what will come of that afterwards. We know there's always been a lot of requests for different opportunities, but we thought we'd give it a try. It's a stretch for us, but we've been having such great success with these and with them really being interested in seeing what would happen. So you'll see something coming out in the next few weeks or early June. We'll have an orientation meeting in June where parents will come. It's going to be a supported space. We're going to need someone from home that's there with them online, somewhat supporting them at the level at which they need it. So just watch for information that will be coming out soon. And we'll be continuing with the speaker series. And we're just really excited. We're very grateful for this opportunity to meet with folks. And the girls we're looking for the ages of 20 and up is what we're calling it, and kind of come to that orientation, see if it seems like a fit for your daughter, and we'll go from there. But they're super excited. There'll be a survey that they'll ask folks to fill out so we know how to support them and whether we can. So if you have any questions about that, you can email Lauren and I. But that was our big exciting announcement, and we look forward to continuing. Don't forget your surveys. Those are super important. And that's going to be where you're going to continue. You're going to ask for your recording if you'd like it. I want to thank you again for presenting today. Doctor, I can't tell you how I learned a lot. I felt like I was on Bill Nye the Science Guy or something. I just never really been exposed to that much information about the eye. And for somebody who has some pretty significant vision loss, it was really cool to listen to. So thank you so much.
Thank you all so much for having me. This was very, very good for me as well. And yeah, and thank you for sharing your evenings with us.
Yes. And Susan, I see your question, and it has been in discussion. The hardest thing is finding experts because that's such new ground in the RTS and aging. We're learning as we go, as our individuals with RTS are having longer, more vibrant lives, and so we're learning. So I will put that on our list. Next national conference. Boy, keep asking us, guys. Keep asking us, because it's not something that's on the direct horizon due to funding, but a conversation of when we can maybe have a gathering of sorts. So it's never off our radar, but I can't say that right now we've got it in our sights either. But keep asking, because the more you ask, the more we go to others and say they're asking. And it looks to me, Susan, like you're typing. I don't want to wrap things up if you're still adding another question. So, and again, do your surveys, and thank you so much for coming. Oh, yes. And Susan, I know we've talked before, and I think I've actually spoken to your daughter too. But let me tap that into when Ilka goes to the international conversations periodically. Let me see if there's an opportunity for her to begin a discussion there. So thank you so much. And we will see you soon.
Lauren, I'll stay until the 8:30 mark, just in case.
Perfect. And as
That's
people
really
leave,
nice. Thank you.
we can do a quick debrief if anybody between the three of us too, because we'd love feedback from you too, just on how things went or what would have made it easier for you. I'm going to start putting folks into the waiting room, because sometimes what happens is they've stepped away. I know we want to have our debrief and let you all go. So don't take it personally. I'm just sticking you in the waiting room because I'm thinking that you got busy.